So this is a relatively quick lecture, so I'm going to break from my tradition, just start off my main slide. There's no other images in here or anything like that. There's actually no pathology in here. This is all just basically flow charts and other ideas and stuff like that. So this is differential diagnosis of abdominal pain, GI laboratory testing. There are me and Dr. Hughes' websites for you with so many questions. Twitter, like I said, I'll get back on it. And then, like I said, I really enjoy teaching medical students. I have a really strong interest in general stomach pathology. I'm a forensic pathologist, so I hope it helps keep me a little bit more non-specialized and kind of not go off into some of the, maybe not as important for medical student areas. I only have one disclaimer slide. So here, read it. Make sure these do not apply to you. If they do, then don't watch them. And that. So the third one didn't apply because there's no images. Here are my references. So on this one, the big one that I'm working off is Dr. Stern's book. So I saw Dr. Stern present at a Association Pathology Chairs meeting, and it was great. And this book is fantastic. I wish I had it available when I was in medical school, to tell you the truth. I was always looking for something like this. And I saw him present. It was amazing. People got there and they said, well, medicine is a lot more complex than this. I'm like, yeah, but this gives you a great foundation. It's really great. And he goes through characteristic things to look for, key points to look for, and stuff like that. So I have no financial interest in the book. I gain nothing from it, but it's a really great resource. Okay, so when you're talking about abdominal pain, one of the first ways is that you look at where it's at. So if it's right upper quadrant, think about what's there. So the gallbladder is there. So biliary disease. The liver's there. So hepatitis. Pancreas goes across there and cause right upper quadrant pain. And then also the kidney can be high enough so you can feel it there. And potentially you can feel diverticular disease. Left upper quadrant, spleen, and then renal as well too. Right lower quadrant is oftentimes appendicitis, and then non-GI ectopic pregnancy, same location, ovarian torsion, pelvic inflammatory disease. Left lower quadrant, diverticulitis, ectopic pregnancy again, ovarian torsion again, pelvic inflammatory disease. Diffuse or periumbilical is a lot of the other. Remember, appendicitis starts out as periumbilical and then goes to the right lower quadrant. Bowel obstruction, gastroenteritis, more generalized disorders. And then epigastrum right across the top, you'd expect biliary disease, pancreas, gastritis, peptic ulcer. So with these, think about where the pain's coming from. Think about, use your basic anatomy. Look at it. What are the underlying organs are there? And then you can start thinking about disease processes. So the other thing I really liked about when Dr. Stern talked about this stuff is he talked about breaking stuff up. So if you is there a single episode? Have they had multiple episodes? Have they have chronic symptoms over time? Or is episodic and chronic, which I think really helps. So if there's a single episode, usually what that means is that somebody with a multiple episode type disease can present with their first time with a single episode. But oftentimes if they have a single episode, it usually means that it's something you die from if it's not treated. So appendicitis obviously is very bad. Peritonitis, rupture of abdominal aortic aneurysm, ectopic pregnancy, splenic rupture, ovarian torsion, acute myocardial infarct. These are all things that can be a one-time cause of abdominal pain. Whereas with multiple episodes, you think about things like biliary disease every time they pass a stone. So they might have no symptoms in between, but whenever they pass that stone, they have it. Diverticulitis, same thing. You can have diverticular disease, be completely asymptomatic, but if it gets inflamed, which happen more than once, then they get that. Non-GI diabetic ketoacidosis, known causing abdominal pain. Nephrolithiasis, same thing. You pass one stone, you may have more. You have to pass other ones. Pelvic inflammatory disease. Chronic mesenteric ischemia, inflammatory and irritable bowel syndromes, things that just don't go away. Hepatitis, gastritis, peptic ulcer, and then episodic and chronic is pancreatitis. So pancreatitis can be chronic, and then you can also have intermittent acute pancreatitis. So I thought this is a great way to look at it. Think about it. Think about, have they presented this way before? Yes. Okay, it's an episodic type condition. What would you think of in your differential? Okay, so he talked about critical signs and symptoms. And this is one good thing about his book. He basically goes through and he really wants to make sure you understand. And I've been told the USMLE is very much like this. They want you to be able to identify things that, hey, if I don't identify the problem now, this patient might die. Those are very critical for you to know, so I thought these are very useful. So peritoneal findings, when people have a peritonitis, they get rebound tenderness, they get rigidity where it's firm, and then guarding where they really don't want to be touched. So with those, you just think about things like talk about, like perforated peptic ulcer, appendicitis, inflammation, things like that, spontaneous bacterial peritonitis, and somebody with cirrhosis. And then another one he talked about was unexplained hypotension. So unexplained hypotension, and if you know that if you have a reason for why they have hypotension, that's explained. But this means if they come in, they have abdominal pain and they're hypotensive, and there's no reason for it, then it's probably something related to certain disease processes that can be causing it. So he said unexplained hypotension can be due to sepsis, so kind of that generalized dilation of the vasculature associated with it, and also due to hemorrhage. So we've talked about peptic ulcer, splenic rupture, obviously can do that, ectopic pregnancy can rupture. And then with sepsis, biliary disease with acute cholecystitis, that can lead to sepsis. That can be a very serious condition. You can die from acute cholecystitis. Pancreatitis, same thing, acute pancreatitis. Appendicitis, same thing, acute pancreatitis. If the appendix ruptures, it can allow air. It can allow also peritonitis and things like that. Diverticulitis, same thing. If the bacteria get through and get out, it can inflame the peritoneal cavity and that. So that can lead to sepsis, and then because of that, they're going to get unexplained hypotension, okay? So if they have a reason for being hypotensive, you know it, it's not explained. So you also talk about in the epigastrium. So this is combining the location and the type. So in the epigastrium, episodic, you could think of biliary. Chronic is usually more of a gastritis, peptic ulcer. They usually don't present suddenly, although I guess it would be possible if somebody has a perforated peptic ulcer, they could all of a sudden have a sharp punctuation of it. But just the disease process in general is not really episodes. It's more like just ongoing. And then remember, both episodic and chronic pancreatitis, kind of ongoing, but can also have acute pancreatitis episodes. In the right upper quadrant, episodic and biliary disease, chronic hepatitis, because it just doesn't really go away. And then once again, both episodic and chronic pancreatitis. So I thought that was a great way to look at it. I thought location, then also what type is it? Are they episodes, or is it chronic, just continually, plus minus going up and down here and there? Okay, so we talked a good one about biliary colic, and I gotta say, I really never understood biliary colic until I read his stuff really good. So biliary colic, anytime you have a crampy pain, it would be because usually there's something being squeezed down a tube. And so it's commonly this crampy pain is associated with biliary colic, where the gallstones get into the bile duct, nephrolithiasis when they get out into the ureter, and then also if you have some type of obstruction of the intestine. So anytime you have a tube filled with something that's blocked, there's a good chance you're going to have crampy pain. And so it's going to come after eating, because that's when the gallbladder gets compressed, and that's when it squeezes out and the little stone goes out. And then usually it can last anywhere from upwards of greater than 30 minutes to multiple hours. When it lasts a long period of time, that's when there's a good chance that they might have developed an infection. Okay? So if they just have biliary colic, that's going to be a stone in the duct. If the pain lasts for greater than 4 to 6 hours and they start getting a fever, there's a good chance they have acute cholecystitis. That's also due to a stone in the cystic duct. Okay? But if it lasts greater than 4 to 6 hours and it's associated with fever and also liver function changes, so jaundice, elevated ALT and AST, then it's in the common bile duct. Because if it's just in the cystic duct, it's going to block flow of bile from the gallbladder, but the flow of bile from the liver can still get down through the common bile duct. Whereas if you go into the common bile duct, you block the whole thing. And then that's going to back up and affect the liver. So I thought that was a great explanation from him. He's got a nice little picture too. Okay, so we're going to talk about AST, ALT. AST, ALT, if the AST, ALT ratio is greater than 2, pretty good chance it's an alcoholic liver disease. And then the other ones are up there. If it's less than 1, greater than 1. And remember, there's really no absolutes in a lot of these general guidelines, but those are some of the ones that are possible. When the AST or ALT is really, really high, you got to think of something like an acute viral hepatitis, an ischemic hepatitis, or something that's toxin or drug-induced, something that just knocks out a ton of the liver. Whereas if it's greater than 500, it's not likely alcoholic liver disease. Usually that doesn't rise above an AST of 300. Okay, then he talked also about bilirubinemia. So bilirubin, is measured as total bilirubin, direct bilirubin. Direct bilirubin is conjugated. So the way I remember that is it means it can directly leave the body. They cannot measure unconjugated, so basically you have to take the total bilirubin, basically subtract the direct, and that gives you the unconjugated. So remember, unconjugated comes from usually the breakdown of hemoglobin, so people have a hemolytic episode or something like that, whereas conjugated can come from damage in the liver or damage beyond it that doesn't allow it, once it's been conjugated, to get out into the GI tract. So it says basically what you can do is you do a urine dipstick for bilirubin. And if the urine dipstick is not positive for bilirubin, then there's a good chance it's unconjugated hyperbilirubinemia. If it is, then there's a good chance that it's conjugated. So unconjugated hyperbilirubinemia, I just mentioned hemolysis, where breakdown of the red blood cells. So if somebody, like, for example, glucose 6-phosphate dehydrogenase deficiency, they could get an unconjugated hyperbilirubinemia. Ineffective erythropoiesis, where the cells basically break down as they're forming and don't function right. Gilbert and Kriegler-Nager, as long as I pronounce those correctly, are from an inability to conjugate it. One has a decreased number of enzyme. The other one has a marked deficiency in present in kids. So Gilbert syndrome is somebody, relatively normal health, everything like that, but if they get stressed out, they could become jaundice because they just get too much. And then also resorption of hematoma could do it because you have a ton of blood in there. So if you have a ton of blood, you break that down, you can get unconjugated. So if it is yes and the urine dipstick has it, then what you'd want to do is you'd want to look at, is the ALP increase out of proportion to the AST? You'd want to look at is the ALP increase out of proportion to the ALT increase, or is the AST-ALT increase out of proportion to ALP? If it's ALP, then there's a good chance it's something involving the bile duct system. So you'd want to get some type of ultrasound or some type of imaging that's going to see if they dilated or not. If they're dilated, then they have an extrahepatic cholestasis. If they're not dilated, intrahepatic. And if the AST increases out of proportion to the ALP, then it's something within the liver. So alcoholic hepatitis, cirrhosis, drug-induced injury, or something like that. So this was just kind of a good way to look at it. And like I said, this is the very beginning. There's a lot more to it than this, but hopefully this will give you some good guidelines. And like I said, Dr. Stern's book and Dr. Desai's book, if I pronounce that correctly, is also just fantastic. It's really small. If you can get a copy of it on eBay or Amazon, once again, I have no financial connection to him either, but it's a great one for going through, and he goes through, okay, if you have this lab test, what do you do? And it gives you some guidelines and stuff like that. Both of them are great for helping form differential diagnoses and for understanding the lab testing. So, okay, so once again, use reflection. Just think back. What were 5 things you learned from the lecture? Hopefully I learned 5 things. And like I said, this is a great technique. It helps you cement the material. I don't give a summary slide because of this. And the medical student, like I keep talking about, I'm sorry, I have to repeat stuff in every lecture, but I have to assume people are watching only one lecture. But in Make It Stick, they talk about student, bottom of the class, top of the class, using this one technique. So I hope you've learned something from the lecture, and thank you.